It's July 12th, 2024, and this is the Room Now podcast. Hi, I'm Dr. Jack Cush, executive editor of RoomNow.com. This is our return from the holiday vacation, and we've got a lot of interesting articles that we put up this week. Some of these have got to be of interest to you. I'm going to start off with some negative studies. I don't know if you've seen the research, but there's always been this research about zoledronic acid, reclass being having some efficacy or some utility in the treatment of osteoarthritis. Well, there was an IV zoledronic acid study in 222 knee OA patients who had symptomatic knee OA, but were not bone-on-bone stage 4 Kellgren-Lawrence joint space narrowing. And it showed after 7 years of follow-up, those who had the zoledronic acid therapy had more requirements for total knee replacements than those that got placebo. So the hazard ratio was a negative 4.5-fold higher odds, or it says hazard ratio 4.2. Anyway, that's what it says. Point is that you get that it didn't work. In fact, it failed quite miserably. Colchicine, also now a big drug in the cardiology field. I saw this study I thought you might want to know about. It's not really a rheumatology study, but it's called the CHANCE-3 study, a double-blind randomized placebo-controlled trial of 8,000 adults over the age of 40 who have either mild to moderate symptoms of a stroke or a TIA, and they have elevated high sensitivity CRPs greater than 2 milligrams per liter. And they showed that half the 4,000 or so people who got colchicine, 0.5 BID for a few days and then once a day for 90 days, had no protection against subsequent strokes in 90 days. So when you looked at the two groups, the subsequent stroke rate was 6.3% versus 6.5%. No significant difference, a negative study. Speaking of negative studies, the ones that really have bothered me in recent years were those studies that look like they might work regarding vagal nerve stimulation as a preventative non-pharmacologic intervention in rheumatoid arthritis, that basically vagal nerve stimulation would decrease TNF levels. It would be like using a TNF inhibitor. The original studies, uncontrolled by Mark Genovese, looked really exciting, but then the subsequent studies didn't look so good. And then the auricular stimulation ones that were supposed to sort of simulate vagal nerve stimulation, those failed. So here's another one. It's a preliminary study. It's called the RESET-RA study. And these are preliminary results, so I don't have details. But they said their primary endpoint, and this was an actual implanted vagal nerve stimulator. It's usually done intermittently, not continuously. They read out an ACR20 response rate in RA patients who had not responded to usual therapy like methotrexate, 242 patients, 12-week endpoint, and significant results suggesting that vagal nerve stimulation would be beneficial. But again, we don't have the results on this two-stage, multi-center, randomized, sham-controlled, double-blind pivotal trial. So you'll be looking for that. Maybe that'll get presented at ACR. It wasn't presented at EULAR. We don't report enough about fibromyalgia here, and I found this large registry analysis of 1,800 plus PSA patients from the old Corona registry, now called CORE-EVITAS. And they found amongst these 1,823 PSA patients that 11% met criteria for fibromyalgia. Moreover, 20.6 or 21% had evidence of widespread pain. Both of these significantly impair our ability to adequately assess these patients or to successfully treat them. Fibromyalgia in this subset, or in that subset, fibromyalgia subset of patients with PSA were more likely to be female, have depression and anxiety, have impaired function, higher BMIs, meaning obesity, comorbidities. It was correlated with CDAPSA scores, patient pain, and tender joint count. So again, you must be aware that secondary fibromyalgia and widespread pain can affect our patients with inflammatory arthritis. Bimekizumab, a drug that's being developed for psoriasis, actually approved for psoriasis, being developed for psoriatic arthritis and axial spondyloarthritis, was studied in two large phase 3 trials, the MOBILE 1 and MOBILE 2 studies, And we've reported on this from last ACR, but maybe you missed it. Bimekizumab, the dual IL-17 A and F inhibitor, was shown to prevent the onset of uveitis in those two studies. So these are AxSpA patients given either placebo or bimekizumab, and showed that it worked on AxSpA endpoints. But patients couldn't enter the trial if they had active uveitis. They might have had a past history, but few did. As far as new episodes of uveitis, it was like 0.6% in the bimekizumab group and almost 5% in the placebo group. And this was highly significant. In the small subset who had a history of uveitis, again, they had a significantly lower rate of developing uveitis if they were on the bimekizumab IL-17 dual inhibitor. 6.2 events per 100 patient years for bimekizumab versus 70 if they were on placebo. Looks like you can add that to your list of drugs that will prevent uveitis. I don't know if you've had this head scratcher that I've had about paradoxical drug reactions. We've seen, paradoxical reactions with TNF inhibitors causing psoriasis and causing IBD. Well, we have paradoxical psoriasis being reported with IL-17 inhibitors. So this is a literature review. They identified 35 patients. Almost all of them were SPA patients. They either presented, as far as their psoriasis, either as palmoplantar pustular psoriasis or plaque psoriasis. But again, the palmoplantar psoriasis is what you see with the TNF inhibitors causing psoriasis as well. Anyway, this occurred a median of 11 weeks after they started the IL-17 inhibitor. A third of them continued the IL-17 inhibitor and got better. 2/3 they had to stop the IL-17 inhibitor and switch to another drug effective, another biologic effective for psoriasis, and they got better. So it's a little bit of a selective reporting. Everybody got better, whether they got better by stopping or not. Again, the data on TNF inhibitor associated paradoxical psoriasis is about 1 in 1,000 cases. Most of them being, again, that palmoplantar variant, which is very difficult to treat. And the treatment is you got to stop the TNF inhibitor. Here, is it going to be the same with IL-17? I don't know. We need more reports like this. Some of you have asked questions about, do you only do rheumatoid factor and CCP testing? Do you do IgA rheumatoid factor and IgG this and these other smaller selective analyses of autoantibodies that may appear early before the onset of disease? Anyway, this is an early arthritis clinic analysis. Actually, patients entering the T-REACH trial, which was an early arthritis study, showed that IgA-ACPA was present in 23% of those patients, which was significantly less than, I think it was 70% for the IgG-ACPA, but it overlapped with IgG-ACPA in 94% of the cases. In this population, 90% of patients were IgM rheumatoid factor positive. The point being, doing IgA antibodies didn't matter at all in the assessment of these early arthritis patients, had no predictive value. I take that as a teaching point. I found another interesting study on difficult to treat RA patients. This is from Tom Taguchi's group in Japan, I believe. 5-year results, 150 difficult to treat RA patients. They saw, and they don't give me the incidence of D2T-RA, it's generally about 10%, maybe as high as 15% in some studies. Anyway, in their study, of the 150 patients they followed, 45% of the difficult RA definition resolved, meaning they ultimately responded, but 50% persisted and 5% died. The resolved difficult to treat RA patients were younger, had more treatment changes, more IL-6 use, suggesting that maybe you should be treating them with newer drugs, especially if they're younger. Now, again, is the IL-6 use going to be selective here? It tends to be used secondarily or as third line in Japan, so I don't know how it's going to pan out with the rest of the world. We need to wait and see. Mortality was in this cohort of 150 difficult to treat patients, and I said it was 5%, was predicted by comorbidity steroid escalation, okay? And there the odds ratios was comorbidities 3.5 fold higher risk with comorbidities that were high, like 3 or more. And steroid escalation had a 32-fold higher risk of mortality. Not good. Takayasu's arthritis, we're sort of wrapping up now. If you give them biologics, will it matter? Will it help? In this cohort analysis of 75 patients with Takayasu's, 40 were treated with conventional DMARDs, methotrexate, leflunomide, that kind of thing, azathioprine. 35 were given biologics, and they showed that that overall a reduced artery thickness was seen in 73% of their patients. 31% decreased their arterial wall thickness by more than 25%. And in the end, it was either the use of a biologic or other immunosuppressants like azathioprine that were able to reduce arterial wall thickness when they compared the results to those who just got conventional DMARDs. Makes a case for using biologics, and most of the biologics used here were TNF inhibitors. Lastly, there's this study about pollution and the risk of lupus. I got two studies on the risk of lupus. And one is that the study from the UK Biobank, almost 500,000 people, and they actually did collect data on exposure to nitrous oxide and other kinds of pollutants. They showed that in the 399 patients who had lupus, they found a 18 to 27% increased risk of lupus when they were exposed to these environmental pollutants. And it was even higher in lupus patients who had a genetic risk. I don't know what that's going to be. They didn't actually detail that in their report. But there's, we reported like 3 months ago about polycyclic aromatic hydrocarbons also increasing the risk of lupus in the general population. And there's another report on RheumNow from yesterday about the pathogenesis of lupus, and it talks again about environmental pollutants being important in the generation of the chemokine CXCL13, which drives T cells to make more follicular helper T cells that will drive B cell activity, again related to pollution. The other report comes from the Nurses' Health Study. This is from Karen Kostenbatter's group, and in this study, lupus wasn't all that common. So amongst the Nurses' Health Study, 200,000 nurses in two different iterations of the Nurses' Health Study, they had like 4.5 million years of observation, but only 212 cases of new lupus, right? These women tend to be a little bit older, I think, but nonetheless, that when they looked at their diets and they looked at the top tertile who were taking ultra-processed food, a Western diet, Big Macs, French fries, donuts, these had an adjusted hazard ratio of 1.56, meaning 56% higher risk of developing new onset incident lupus compared to those in the lowest tertile. So this is also soft drinks and sugar sweetened products. So the idea is that, there's this picture of autoimmune disease now that has the environment as a strong predictor of risk. And it may be that with certain genotypes that the risk gets even higher. And now you produce the autoimmune state, which is the preclinical state, which may evolve with a few other triggers into clinically manifest disease. I think this kind of research is really framing our thinking, or maybe not just, maybe confirming the way our thinking has been framed in the last several years about how you get autoimmune disease. And the last report is on the cost effectiveness of biosimilars versus leflunomide. This is a Korean database that looked at, I think it was 26,000 patients, and using Markov modeling, which is how you assess the cost efficacy of a drug and whatnot. And here they looked at the lifetime costs of RA and the quality adjusted life years. They compared starting with leflunomide to starting with the infliximab biosimilar CTP13, that's like Inflectra and Renflexis, or the adalimumab biosimilar ABP 501. And the lifetime cost of the disease was $154,000 with leflunomide, $152,000 with biosimilar infliximab, 145,000 with biosimilar adalimumab. And the quality adjusted life years are all exactly the same. The point being that after methotrexate, should you play around with conventional DMARDs, or now with the cost of biosimilars becoming reasonable, can we go right to biosimilars? This is going to challenge maybe how we treat our patients in the future. Again, the great promise of biosimilars was going to be much cheaper, making it more widely available, and more patients being more aggressively treated. But, in the United States, we've been very slow on the uptake of biosimilars. I think this data is going to help us make up our mind. That's it for this week on the podcast. Make sure you go to the website to check out these citations and more. We'll talk to you next week. Take good care of yourself.